Good afternoon. My name is Chelsea Dorsey. We're going to be talking about how workforce demography impacts clinical outcomes in vascular surgery and vascular disease specific health disparities. I'd like to take this opportunity to thank the Society as well as the DEI Committee for the opportunity to speak. I have no relevant disclosures for this talk. Our objectives are going to be to hopefully understand general trends in the vascular surgery workforce as it relates to diversity. In addition, we're hopefully going to understand who physicians treat and how that may have an impact on outcomes for our patients. Hopefully, we don't have to spend too much time here, but building a diverse workforce in vascular surgery is incredibly important. And with it comes several benefits, including better learning environments geared toward developing more open-minded surgeons striving for cultural humility. In addition, as we will talk about later, some patients not only prefer racial and ethnic concordance with their physician, but in some cases, it also leads to better outcomes and can help our profession to be viewed as more approachable and representative of the real world. Beyond that, focusing on diversifying our vascular workforce is also just the right thing to do. There have and continue to be some exclusionary policies in place that make it very difficult for underrepresented minorities to enter our profession. We have the opportunity to correct some of that with this work. And finally, one of the key parts of this whole discussion is that underrepresented minorities and women disproportionately choose to serve minority and underserved communities. So if we are serious about this, we should be heavily recruiting these individuals who have traditionally demonstrated a commitment to fighting health inequities and providing care to those who are most vulnerable. Keeping that last point in mind, healthcare disparities are widespread in vascular surgery. Minorities are more likely to present with advanced PAD and undergo amputation. In addition, complications and death after EVAR are also more common in the minority population. The factors contributing to this problem are numerous, and there is not enough time to fully describe the complex nature of this issue. But inequities in socioeconomic status, decreased access to healthcare, physician bias, and systemic discrimination are a few. To address some of these issues, many have proposed increasing the number of underrepresented minorities in medicine. How bad is the workforce problem for vascular surgery in particular? Well, it's pretty dismal, especially as it relates to Black trainees entering our field. We've seen a steady increase in women entering our field, in part because of the broader appeal of the integrated paradigm, and a modest increase in Hispanic trainees. Unfortunately, over the last several decades, there has been essentially no significant increase in Black trainees entering vascular surgery. This is in keeping with much broader trends. When we look at the total GME pool, which over the last 5 decades has also seen a steady increase in women, the pink line, but stagnation is really the only way to describe what we see when we think about most of the lines that represent underrepresented minorities. What is even more troubling is that when we think about how long it might take to correct the deficits, we see specifically as it relates to Black trainees, if we double the number of matriculants, it will take us nearly 70 years to get to a place where Black physicians are adequately represented. For Hispanic trainees, it will take over 90 years. Sobering data, especially when you consider that we have seen almost no increase in the number of matriculants in vascular surgery over the past several decades, particularly for Black trainees. So a doubling would be optimistic, to say the least, but obviously let's aim high. Now I want to transition into considering some of the data as it relates to who physicians of color care for. As you can see here, Black physicians were significantly more likely to care for minority patients as a whole, Black patients, low-income patients, and Medicaid patients. Likewise, Hispanic physicians were significantly more likely to care for minority patients as a whole, Hispanic patients, Black patients, low-income patients, Medicaid patients, and the uninsured. And notably, similar findings are seen with our Asian colleagues. So this matters, right? If we supercharge our vascular workforce with physicians of color, there's a higher potential for many of our vulnerable and underserved patients to have surgical providers motivated to serve them. And let's be clear here, I'm in no way suggesting segregation of care or diminishing the efforts of non-minority vascular surgeons who care for these populations, but merely pointing to this clear role that minority physicians play in caring for the disadvantaged and fighting some of the health inequities that are omnipresent in our field. So let's think about this. If we can get more underrepresented minorities into vascular surgery, that's step one. There's actually some automaticity to step two, which we showed in the previous slide. Those individuals are more likely to serve in areas with vulnerable and disadvantaged populations. Step three is interesting because some patients like this racial and ethnic concordance. Let us not forget that there is a long history of distrust in the medical community with some of these populations for good reason. So there is comfort in sitting across from someone that looks like you. I can't tell you the number of times I have stepped into an exam room and noted the smile on my Black patient's face, which is often followed by an, "Oh my God, Dr. Dorsey, I'm so glad to see you." And I'm glad it's you. Personally, I can also speak to how it felt to grow up never seeing a doctor that looked like me. That inherently makes the medical field feel less approachable to some patients. But when you look at this 2020 study, the data is pretty clear. When Black patients were shown video vignettes from Black physicians discussing CABG, Black patients were more likely to understand the perceived necessity of CABG and also more likely to undergo CABG when they had a Black physician. So this matters to patients when it comes to decisions being made about their care. And even beyond discussions about surgery, the data suggests that adherence to cardiovascular medications is better when there is racial concordance, especially as it relates to Black patients and also language concordance with Spanish-speaking patients. So how do deficiencies in our workforce interplay with vascular surgery health inequities, such as those seen in PAD? This was a recently published review by Demzas and colleagues, specifically looking at the disparities involved in peripheral arterial disease. And I encourage everyone to read this paper. They do a great job here of laying out the complex nature of this problem, as well as suggesting specific action items to address the issues. But for the purposes of this talk, we can see how workforce demography actually has a direct impact on PAD outcomes if we merely focus on the access to care issues. So access is obviously a broad term, but certainly under that umbrella is the sheer lack of vascular surgeons and other specialists available to some of these more vulnerable communities. Again, if we can think about ways to recruit more URIM into our field, there is an opportunity to see some meaningful change here. And the inevitable question is, how do we make a dent in the numbers? How do we start to move from a flat curve to obvious growth? So all of this on this slide is really my wheelhouse, and I hope we have some time to further discuss in the panel. But it starts with tracking the data and establishing clear outcome metrics. From there, it's a commitment from leadership, not just chairs of DEI committees. I'm talking about society presidents, department chairs, medical school deans, section chiefs, program directors. Everyone must be crystal clear in this quest towards improved workforce diversity. The other pieces to the puzzle, creating an inclusive surgical environment, establishing robust mentorship opportunities, and emphasizing early recruitment with robust pathway programs, are only possible if DEI is fully integrated into all aspects of the organization's daily ongoings. And of course, there must be a paradigm shift when we think about surgical excellence. Diversity must be embedded in that definition for us all. And I don't mind being a broken record here because this point is actually critical. In conclusion, we continue to see challenges in our workforce demography and vascular surgery. As we have discussed, addressing the underrepresentation we see in racial and ethnic minorities is one way to combat the health inequities that are widespread in our field. Again, thank you for the opportunity to speak.